Good afternoon, everyone. My name is Alberta Noonan, and I'm from the New England QIN-QIO, and I will be your moderator for today's webinar, the new hypertension guidelines. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accepting the recording at the end of the webinar. And excuse me, I'm going to try muting the lines again. Okay. The phone lines will be on mute for the duration of the presentation. We'll take questions at the end of the presentation. At that time, I will provide you with instructions on how you can answer a question over the phone. You can also pose a question in the chat box throughout the presentation. Please make sure to send the question to all participants. Today's presentation is co-sponsored by the New England QIN-QIO and the New Hampshire Division of Public Health Services. Our presenter today is Paul Whelton, BM, MD, M.Sc. Most recently, he chaired the 2017 American College of Cardiology and the American Heart Association Blood Pressure Guideline Writing Committee, and is a recipient of the American Heart Association Population Research Prize and the Excellence in Hypertension Research Award. At this time, I'm turning the presentation over to Dr. Whelton. And Doctor, be sure to press #6 to unmute your line. Dr. Whelton?
No? Yes, can you hear me now?
Yes, now we can hear you.
Okay, I pressed a couple of times. So let me thank you, Alberta. It is a particular pleasure to be with everyone today. Greetings from New Orleans, where we're still in the morning, and I know you're in the afternoon. It's a great pleasure to talk about the 2017 American College of Cardiology, American Heart Association Blood Pressure Guidelines. I'm going to make that a little simpler and say ACC-AHA. We'll talk a little bit about clinical implications and our concordance with other guidelines. I have no conflicts of interest. So, just get to the next slide here. So let me just say a few words of background about the guidelines. So this was an initiative that was led by ACC and AHA, but many other partners agreed to be a part of the guideline process, and you can see the list here, 9 other organizations. The writing committee was a really hard-working, great group, multidisciplinary, a mix of primary care clinicians and specialty clinicians. We had 2 lay patient members of the committee also, who were all very active. Nobody had a commercial relationship with pharmaceutical industry or the device industry related to blood pressure. We had an independent external review committee to whom we sent some questions for systematic review and meta-analysis. And the process was very structured. It was a quite formal process. We ended up spending 2 years to get the guideline written, and then a year of review around the world. It is a comprehensive guideline, so it is long, but we've written it in 15 sections and many subsections, all of which have an identical format, so it's relatively easy to navigate. We ended up with 106 formal recommendations and a lot of evidence to support those recommendations, including almost 450 detailed evidence tables. Each recommendation has what we call a COR, classic recommendation. It just basically says how important we think that recommendation is. And each recommendation also has an LOE, or level of evidence. What's the quality of the evidence supporting the recommendation? So I mentioned it underwent extensive peer review within the U.S. and around the world, and we responded to over 1,000 comments, and then eventually had to go through approval by the governing bodies of the 11 participating professional societies. So it wasn't an overnight guideline. It was one that, whether you agree with the recommendations or not, was a pretty thoughtful process. Now, I am not going to cover everything in the guideline, but I wanted to select a few issues that I think are important and maybe different to previous guidelines. I will underscore blood pressure measurement. I'll talk about classification system, our approach to treatment decisions, the actual treatments we recommended and the targets during treatment, and then some strategies to improve control rates. And I'll try to do that rather briefly. So you can't avoid talking about blood pressure measurement. It is what we in the U.S. would call the elephant in the room. We have very poor blood pressure measurements typically in clinical practice. And they can either underestimate or overestimate blood pressure. The more typical pattern for routine clinical practice is that pressures have tended to be overestimated, probably somewhere in the range of 10 to 15 millimeters of mercury. Now that's very substantial and will lead to a huge overdiagnosis problem. Research measurements tend to follow the recommendations better, and home and ambulatory blood pressure measurements tend to be much closer to what we get in most of the research studies. And when I say research, I'm talking about the studies that underpin our understanding of blood pressure and risk, and the clinical trials that tell us about the effect of lowering blood pressure. So we spent a good deal of time worrying about this, and if there's been an aspect of the guideline that I think is useful, it has brought this problem to the fore. And we've known for years that unlike something like weight, blood pressure is very variable. Anyone who's measured blood pressure knows that, and we've known some of the factors that can lead to systematic errors or predictable errors, and factors that lead to what we call random or unpredictable errors. And they can be avoided. And the way to avoid them are to properly prepare the patient. For now, several minutes of rest in a quiet room, we recommended 5. It's important to have the proper technique using a validated device, using the proper cuff size, positioning the cuff size properly. Mostly we use automated or oscillometric devices these days, but if one is using the more traditional auscultatory approach, you can either use the bell or the diaphragm. Doesn't really matter, but positioning that over the brachial artery is important. Taking the right measurements, documenting them, and making sure that we give them to the patient. So the process is relatively simple, but it's not followed. And frankly, if we had in laboratories the type of quality control problems we have in measuring blood pressure, it would be closed down immediately. No airline would fly with the type of quality control we tolerate in clinical practice. And so that's a huge problem, not easy to solve. If it were easy to solve, it would have been solved by now, but we need to continue to work on it. Now, next thing I want to talk about is classification of blood pressure, and of course this is something that has evolved over the years. In the more recent past, we have some stability, and the things we've said is, well, first and foremost, for any classification system, the important thing is to measure the blood pressure properly. So basing the classification on 2 or more accurate readings on 2 or more occasions and averaging those blood pressure readings. Office measurements, clinic measurements, have really been what have been used in most all of the risk studies and all of the clinical trials. So they are sort of the gold standard, if you will, of blood pressure measurement, and yet we understand that what we see in the office is a very small window on what the patient is exposed to. And so we, like others, have recommended that high pressures in the office should be confirmed by out-of-office blood pressure measurements. The best ones would be ambulatory blood pressure monitoring, but that's not feasible in many instances, so home blood pressure is done by a patient who has been trained to measure blood pressure properly is a reasonable substitute. So confirming high blood pressure before we embark on a lifetime of treatment, and recognizing when there is a discrepancy between what we're seeing in the office and outside. Either white coat, high in the office, normal outside, or masked, high normal in the office and actually very high outside. Now, we've recognized in the more recent past that white coat and masked hypertension are quite common, in the order of 10 to 25%. They're challenging because we really don't have treatment trials dealing with them, but we gave some advice, and I think most people would agree that masked hypertension, based on what we know, probably ought to be treated with non-pharmaceutical drugs, and white coat perhaps with non-pharm can be followed, but certainly those with white coat, 2 to 4% every year graduate to sustained hypertension. So certainly worth recognizing these two and documenting sustained hypertension when possible. Now, the previous, most recent classification system was introduced in 1993, and with minor modification was what was used in the last major U.S. guideline, the Joint National Committee 7 report of 2003, or JNC 7. And we looked at that classification system, and we felt that what had been classified as normal was very sensible. We kept that terminology. We felt that what had been classified as hypertension, 140 systolic or above, 90 diastolic or above, was very sensible, and we kept that designation. Where we had an issue was in the intermediate category of blood pressure, what had been called pre-hypertension, especially in the upper end of that distribution, 130 to 139 systolic, 80 to 89 diastolic. And after a lot of review and discussion, we felt that that really should be called stage 1 hypertension. So we came up with a system that said normal, elevated, and hypertension starting at 130 systolic and above, or not 80 diastolic and above, and 2 stages. Stage 1 for the lower end of the distribution, and stage 2 for everything above, because really the treatment recommended doesn't vary. The intensity does, but not the type of treatment. So why did we decide to change to stage 1? Because we knew that would be challenging, controversial. Well, the reason's relatively straightforward. It's a mix of risk and treatment experience. So when you look at the risk increases for cardiovascular events throughout the distribution of blood pressure from lower to higher. There is no threshold. The concept of hypertension is a clinical one. It's useful, but it's arbitrary. The body doesn't understand hypertension. It just recognizes levels of blood pressure. So at the 130, 139 systolic category, you're at about double the risk for heart attack or stroke compared to more normal blood pressure. And that category of blood pressure is quite common in the U.S. It's over 20%. And when you associate the risk with the frequency, it would tell you that for almost all of the cardiovascular outcomes, it's hard to ignore this category of blood pressure on the basis of risk. It accounts for 20 to 25% of all blood pressure-related complications. So their side was fairly straightforward and clear. On the treatment side, we knew there were treatments that could be helpful to an individual in this level of blood pressure. So certainly there are a lot of non-pharmacological interventions that will lower blood pressure, and we identified 6 major ones that have been very well proven. In the category of blood pressure we're talking about, they will typically give you about 3 to 4 millimeters of mercury, but when combined, in the order of 7 or higher millimeters of mercury, which is a very substantial drop in blood pressure at this blood pressure range, and most people would believe that is valuable. We also knew that even with low-dose pharmacotherapy in this blood pressure range, you can lower blood pressure, prevent hypertension, and in the most recent trial, prepared prevention trial, we showed that you could substantially reduce left ventricular mass, which is an important risk factor for cardiovascular disease going forward. So all the indications to us suggested that not only were individuals in this blood pressure range at increased risk, but there were things that we could alert them to do. Lowering blood pressure seemed to be helpful. And I'll come to more traditional antihypertensive drug therapy, which usually starts for somebody at a higher level, but we know that getting to levels below this range is beneficial. So that's why we ended up deciding there should be a new stage 1 hypertension. It didn't necessarily mean that everybody with this blood pressure range should receive drugs. Everybody, we felt, should receive non-pharmacological interventions. Mostly this would be lifestyle change, because that's what causes high blood pressure in the vast majority of individuals, about 90% of individuals. It is a mix of poor diet and inadequate physical activity. So essentially, our epidemic of high blood pressure is indeed a cultural phenomenon. And all epidemics, as you well know, are cultural. They come about because our culture changes, and you really only in the final analysis can deal with them by changing that culture back. So the treatment here is a mix of non-pharm for everybody, and then in certain individuals adding in drug therapy. And let me just go to, sorry, I went the wrong way. So in particular, we felt it was important when we were dealing with treatment decisions to understand not only the blood pressure, but the extent to which somebody had an elevated risk for atherosclerotic disease. This is particularly important for stage 1 hypertension, this one over here. So for those who have stage 1 hypertension, but their risk of cardiovascular disease is relatively low, less than a 10% chance of having a major event over the next 10 years, we recommended non-pharmacological therapy. We did not recommend drugs. In contrast, for stage 1 hypertension, where they already had a history of cardiovascular disease, automatically at high risk, or one would use a calculator, and we recommended the American College of Cardiology calculator, and you found that they were at a relatively high risk. In other words, 10% or more chance of a major event over the next 10 years. We felt they should get a combination of non-pharm and drug therapy. Now, for those who have diabetes or chronic kidney disease and also have high blood pressure in adults, they're almost universally at high risk. So it is good to use the calculator, but as a practical matter, one could assume they're high risk and they would get the combination of non-pharm and drug therapy. Likewise, for those who are over the age of 65, someone like me who's an adult over the age of 65 and has high blood pressure, almost invariably they're going to end up with a risk that is higher than what I've mentioned here. So we would say the combination. And we said for those who have stage 2 hypertension, 140 or above, systolic, 90 or above, diastolic, automatically they should get the combination. So those are the recommendations we made. Now, I want to talk about particularly stage 1 here, and why did we think, in addition to measurement of blood pressure, one should look at underlying cardiovascular risk. And that's a departure from previous U.S. guidelines. Well, the reason we did say that is that at any given level of blood pressure, there's enormous variation in the likelihood of having an event over the next 10 years. Now, that's what I'm showing on this slide here. And it's more than a 30-fold difference. So those at low cardiovascular risk are very unlikely to have events, even though their counterparts at the same level of blood pressure who have high risk are very likely to have events. So there are more than 30% chance up here, less than 1% chance down here. And as you move from lower to higher pressure, the risk goes up, but it particularly goes up in this upper end of the range. And those who are low risk still have little likelihood of having an event. So if the idea of treatment is to prevent an event, they're not likely to have an event here, so there's not much value to adding drug therapy. You just get the risk, but you're not going to get great benefit. And when we look at treatment in the antihypertensive drug treatment trials, across underlying levels of cardiovascular risk, the relative reduction in risk, or if you will, the percent reduction that you get from lowering blood pressure is pretty constant. On the other hand, when you look at absolute reduction in risk, which is what a patient would be most interested in, or should be most interested in, those who start off being treated and have a high risk for cardiovascular events are the ones who get the greatest benefit from treatment. So both of these factors influenced our thinking about treatment thresholds. And for stage 1 in particular, again, we said the important thing here was to understand, were they at substantial risk for an event? If they were not, non-pharm on its own made sense and check them in 3 to 6 months. If they were, non-pharm with drug therapy made sense. Reassess them in 1 month. Stage 2, non-pharm and drug, again, reassess them 1 month. So it's a bit like the question to Sullivan, who robbed banks. Why did you rob banks? And he said, well, that's where the money is. And the question here is, why do you recommend getting an estimate of underlying cardiovascular risk? And it's because you want to go where the events are likely to happen. And that's where the treatment will be most beneficial. So we estimated that changing the classification to include a new stage 1 hypertension would have a big impact on prevalence, almost 14%, or maybe over 30 million new U.S. adults with hypertension. And we, of course, took that seriously, but we also felt that it was important for these individuals to understand they were at risk and there were things that could be done to lower their risk. Because we are more careful about who should get a drug, we actually have had little impact on the prevalence of drug use. It goes up slightly, but not very, very much. So that's a little bit about our treatment, generic treatment recommendations. When it came to treatment per se, as I mentioned, we recommended non-pharm forever, and there are many non-pharm approaches, some of them quite interesting but not sufficiently proven yet. But 6 that are very well proven include weight loss, healthy diet, reducing dietary sodium intake, increasing potassium through diet, physical activity, and moderation in alcohol intake. And all of these will not only improve those with blood pressures in the non-farm range, non-intensive range, but will have an even bigger impact for those who have pre-existing hypertension. So that's clearly the underlying approach to any patient with high blood pressure. For drug therapy, we said, well, the first question is there a compelling indication for a drug that will concurrently lower blood pressure? And there are many such individuals who would come into this category, and particularly as you get older, there's more comorbidity. You'll find individuals who've had a heart attack, or they've stable ischemic heart disease, or they have heart failure, and they may be already recommended a beta blocker or an ACE inhibitor or some other agent that will lower blood pressure. So that's the starting point. Where there are no compelling indications for choice of a particular drug, we said that achieving blood pressure reduction was the key issue, independent of what drugs were used. We felt that diuretics, particularly the long-acting diuretics, such as clofazimine in this country, were perhaps the best drugs, but diuretics and CCBs were often a very good first choice. But looking at the panoply of all of the information and all of the meta-analysis, we said it was acceptable to use drugs from any of four classes: diuretics, calcium channel blockers, angiotensin-converting enzyme inhibitors, or angiotensin receptor blockers. All of these will lower blood pressure, and they are all shown to reduce cardiovascular risk compared to placebo. We further went on to say that most people would benefit from a combination of therapy. And if it's feasible to do that using a single pill, that is highly desirable. It is especially important that there be combination therapy in blacks or African Americans and in those who start off with relatively high levels of blood pressure. So we recommended it generally, but very specifically in African Americans and very specifically in those with stage 2 hypertension with a high starting level of blood pressure. We said the obvious: use combinations that make sense. A diuretic or an A or a CCB will work very well with either an ACE or an ARB. As I mentioned, using a single pill were feasible. In blacks with hypertension without heart failure, CKD, initial treatment should include a thiazide-type diuretic or a CCB. And the only thing we did not recommend is combinations of renin inhibitors. So an ACE or an ARB, or two ACEs or two ARBs. That is definitely a potentially harmful combination, should not be used. What about the target for blood pressure during treatment? Well, we have learned a lot in this arena. We have many trials that help us now that we didn't have for prior guidelines. We have many meta-analysis. This is the largest and most powerful meta-analysis, which our group at Tulane published several months ago. And essentially what it's saying is wherever you start, getting to a lower blood pressure is going to be better for major cardiovascular events. So even down to very low levels of systolic blood pressure, you always seem to do better with a lower compared to a higher, slightly higher, or a substantially higher level of blood pressure. And it's not just all major cardiovascular events. You see the same thing for stroke, for coronary heart disease, and for all-cause mortality. And you see that independent of whether particular trials like SPRINT are included or not included. Once you have 5 or 6 trials, these estimates become quite stable. And it doesn't matter whether you use the type of approach we did in this particular meta-analysis, so-called network meta-analysis, or you do What we also did in this meta-analysis, a direct meta-analysis, was get exactly the same findings. And it's not just our publication. Many have shown the same pattern for meta-analysis. So very convincing evidence that lower is better. We had our independent external review committee look at this question using a direct meta-analysis with a much smaller number of clinical trials than I've shown you in the previous slide. But they came back to us and said, for a systolic below 130, there is compelling evidence that it is sensible to get below that level for all major cardiovascular complications, for myocardial infarction, for stroke, and for heart failure. So absolutely they recommended this approach as well. So we picked 130 systolic. I personally get to lower pressures. I have high blood pressure myself. I take my pressures to lower. But as a whole, the committee were very comfortable and confident of the 130. We put in an equivalence level of blood pressure for diastolic, but it's really only an equivalence. It's not based on the clinical trial. So we said less than 130 over 80 in most people. In older people of my age, systolic pressure becomes the dominant risk factor, so we said just focus on systolic pressure. So that's what I'm showing you on this slide here. Everybody, whether you're using drugs in combination with non-pharm or non-pharm alone, aim for a systolic less than 130. If you're over age 65, that's all you should be worrying about. For younger individuals, it's a good idea to get the diastolic below 80 as well. Usually, once you get the systolic below 130, the diastolic won't be there. Now, one of the groups we worry about is older people, and we worry that we might do more harm than good with treatment. And recent trials have been very helpful. And what they've shown us is, at least for the type of older individual who comes into a clinical trial, they seem to benefit a lot from fairly intensive reduction in blood pressure. And this is the systolic blood pressure intervention trial, or SPRINT. We recruited quite a lot of individuals, over 2,500 individuals who were 75 years or older at baseline. And we looked at their experience, and they did very well. Overall, they did as well as in relative terms as anybody on the trial, and because their absolute risk for disease was high, they derived greater benefit. And we actually looked at the group we recruited and categorized them by whether they were very fit, less fit, or they were quite frail. And in fact, the pattern for benefit with more intensive reduction in blood pressure were seen in all of these groups. We also looked at gait speed, which is a very useful thing to use in practice, because when somebody comes to see you, if they are like me, pretty sprightly, they're at a low risk. If they have a slow gait speed, they're on a walk or something like that, that tells you they're going to be at high risk. So for those, even with the lowest gait speed, they seem to derive a substantial benefit as well. So at least in the context of the type of participants we recruit into trials, we have seen good results in older individuals. We had a very recent presentation, which I anticipate will be published very soon, looking at cognitive factors, cognitive function in the SPRINT trial. And of course, this is mostly going to be in older individuals. And what we saw as a trend towards improvement in dementia was not statistically significant, but we did see a significant reduction in mild cognitive impairment, which for many individuals with dementia, it seems to be the major prodrome. It's a strong predictor of dementia, especially for those with small vessel disease. And that was significantly less common in those who were more intensively treated. The combination of mild cognitive impairment and dementia was significantly less common. And in a sub-study, I'm trying to get rid of this here. Oops. Excuse me. I don't know if you can see the bottom of the trial, but in that sub-study of MRI, the changes in MRI were very consistent also with an improvement. So there's pretty strong evidence from SPRINT and other trials that probably more intensive reduction in blood pressure is likely to reduce the incidence of dementia. We do worry in older individuals in particular about what's called a J-shape curve. And when you look at individuals with lower pressures, they tend to have higher risk. And we looked at that. That's been looked at using observational analysis, even in clinical trials. We saw that in SPRINT in both the standard treatment arm and the more intensively treated arm. And the question then becomes, why is the risk increased here? Is it because low blood pressure is causing cardiovascular events, or is it the opposite, that with individuals down here who have a lot of comorbidity and they just can't mount a high blood pressure? I believe it's the latter. Typically, when we see J-shaped curves, whether it's with blood pressure or sodium or cholesterol or alcohol or weight, it tends to be the latter. They're sick people who can't mount a high blood pressure. When we did a randomized analysis, which is really what you'd like to do to understand treatment effect, at every level of starting blood pressure, random assignment to lower pressure seemed to give more desirable results than higher. In fact, that was greatest for those at highest risk. Whether we're looking at the primary outcome of cardiovascular disease events or all-cause mortality. So that, again, was pretty reassuring. And of course, one has to be careful in older individuals. If they are not well, if they have a lot of comorbidity, perhaps they're institutionalized, and their life expectancy is thought to be not very long, then it has to be a decision whether to treat or not, or how intensively to treat, based on a conversation with the patient and the caregiving team, and perhaps the family. So we always say these are guidelines. They are no more than guidelines, and in the end, clinicians have to be the ones who are in the best position to make recommendations for patients. Well, what about these blood pressure targets we're recommending? Well, they're pretty consistent with all other major guidelines. The Canadians and the Australians suggest a lower target based on SPRINT. They say 120. They do say shared decision making, and both of them say care in following such patients to recognize any potential side effects and deal with them. The American Diabetes Association recommends less than 130 over 80 for adults with diabetes and high blood pressure of high risk for cardiovascular events, and that, in fact, is most diabetics who are adults with high blood pressure. And the European guidelines, which were just released within the last month, also suggest less than 130 over 80. So most guidelines are pretty consistent. There is one guideline in the U.S., the Family Practice American College of Physicians guideline, which is recommending not to initiate therapy unless an older individual has a systolic above 150 and not to go much below 140. That guideline is an outlier compared to all others. Maybe they know something that nobody else knows, or maybe they've got it wrong. I believe they've got it wrong, but all the other guidelines are suggesting much lower targets. And this is just to show we have compared our guideline with the American Diabetes Association guideline. You'll see here concordance to treat, accordance not to treat, and you'll see the discrepancy between these two guidelines is very, very small. So, in fact, most of these guidelines are mostly very consistent, but of course, when people publish, they're usually looking for differences. When the media picks up, it makes a big deal out of differences, many times small differences, and that's unfortunate because it does lead to confusion amongst clinicians and certainly amongst the general public. But there's no way to, unfortunately, avoid that issue. So the last thing I want to touch on very briefly would be hypertension control rates. We are doing a much better. We are doing a much better job in the U.S. of not only treating but controlling blood pressure, but still only about half of all hypertensives in the U.S., even at the 140, that should be 140, excuse me, less than 140 over 90 range are controlled. The situation is much less rosy worldwide and particularly poor in the low and middle income countries. And that's where most high blood pressure is these days: China, India, Pakistan, Indonesia. So a huge problem. We have learned in clinical trials we do far better than this, and in many of the systems of care in the U.S., we do far better than this. And we try to understand what is it we're doing in clinical trials and the good systems of care that get better control rates. And there are several things that jump out. Adherence strategies, using once daily dosing, using combination pills where there are appropriate pills available, strategies to promote lifestyle modification. Team-based care is a huge effect. Starts obviously with the patient and the healthcare professional. That's the nidus of the team. It can include others. If one is in an office staff is if they're in the community and there are community health workers available, taking advantage of them and taking advantage of the support systems, spouses, relatives, friends. This is probably one of the interventions that has the greatest impact on improving control rates. Active use of the electronic health record and using that as a patient registry, who's showing up, who's not, who's taking the meds, who's not. Passive use of EHR has no effect, but it has to be actively used. Telehealth strategies are very helpful where you're getting feedback from what's happening in the outside the office. Performance measures, quality improvement initiatives are also helpful. And financial incentives have a small but statistically significant impact. So these are all approaches that can definitely lead to improvements in control rates. So in summary, we recommend it a lot, but we put a lot of emphasis on accurate measurement of blood pressure for diagnosis and management of high blood pressure. We recommended a diagnosis of hypertension when the average systolic was 130 or above, or the diastolic was 80 or above, if the measurements are done properly. We recommended lifestyle modification as a core strategy for lowering pressure, and the addition of antihypertensive drug therapy for stage 1 hypertension in individuals at high risk for atherosclerotic disease and all stage 2 hypertension. We recommend a target systolic of less than 130 and a good idea to get to a diastolic less than 80, systolic only being the goal in older adults. We recommended a number of strategies to improve blood pressure control, and we were very confident that adoption of our guidelines, even if not complete adoption, would lead to benefit, and we and others have shown from modeling exercises that adoption of our recommendations compared to prior recommendations will likely lead to a very big beneficial impact for adults as a whole, and certainly be beneficial in individual adults with high blood pressure as well. So I want to thank you for the opportunity to talk today. I'll pass on this slide and be happy to take any questions, and I'm going to hand the audio back to Bertha at this point.
So thank you, everyone. At this time, we'll take some questions. If you would like to ask a question over the phone, please press #6, or you can pose your question in the chat box by sending a message to all participants. And also, while we're waiting for people to post their questions, I will re-enter in the chat box the link that will help you get the slides from today's presentation. Okay, so we have a question from Chris, and it says, is the average automatic blood pressure monitor that you would buy at a pharmacy sufficient, or do you have a short list of the ones that have been deemed higher quality?
Okay. So I think you have to hand the audio back to me.
Doctor, you just need to state you're fine.
Oh, okay. Thank you. I didn't realize I was on audio. So we have created, this is an issue, challenge. We have in our guideline several references and 3 different URLs where you can go in and check devices. Many devices, the typical devices that will take brachial blood pressures are indeed valid. So the oscillometric devices are quite good overall. There are, 3 basic approaches to measurement of blood pressure. Oscillometric devices, the classic auscultatory mercury device, and the analog device. So mercury is gradually being withdrawn because of its toxicity. It is, the traditional gold standard. So that's sort of going out of favor. It does give you very accurate blood pressure measurements. The analog is very good out of the box, but it has a valve that is very prone to damage. If the instrument falls on the floor or gets to be hit against the wall, that valve will very commonly get out of whack and you get false blood pressure readings. So more and more, for convenience and for sort of resilience, if you will, we're moving to oscillometric devices. They measure blood pressure in a different way to our traditional approach. They measure oscillations of the vessel wall, and they do an estimate of systolic and diastolic. But that's the direction we're going in. And there are many good oscillometric devices. We thought about measurements at different locations. There are accurate measurements at the wrist, but unfortunately, typically, people don't keep their wrist at heart level, and they tend to move their hand during the measurement. So we stayed with ratio measurements. There are many cuffless measurements, and if you go into your iPhone or your Android device, you will see tons of apps for measuring with the phone. At this point in time, they're not generally valid. Hopefully over time, we will get easier and well-validated measurement methods that will relieve the burden for clinicians, because right now we're concerned about the quality of the measurements. Clinicians are concerned that they're so pressed for time already. We have to decomplicate it and get the measurements out from clinicians, particularly from physicians, to have them focus on the more complicated cases. And over time, I think as we get to more valid approaches that are simple, that could be worn by a patient, that would decomplicate quite a bit. And there's very interesting, there are many interesting trials now that are suggesting that even just instructing the patient on how to manage their own blood pressure, they do better than we do in a clinic setting. So over time, I think this is going to evolve and needs to evolve.
Okay, we have another question from Latina. Is there a specific set of steps to help patients learn to do the at-home blood pressure measurement? Which patients should measure at home?
Yes, excellent question. We did spend a lot of time on this in our guideline as well, and if you go to our guideline, you will see specific recommendations. Again, it's a bit of a challenge right now. So a patient taking blood pressure measurements without any instruction is not going to do so well. It's no better than a clinician thinking they're very good at measuring blood pressure but not really following guidelines. So following general guidelines is important. We included the recommendations. The best way would be for somebody to take measurements at home with a device that will either retain those measurements in the memory or will automatically transmit them to the clinician's office setting. Because sometimes we're all phone biased, and not every patient is this case, but we know that many times patients want to please us, and they will maybe selectively show us the best measurements, but we know in general that what is on the memory in that device isn't always as good as what we're told when somebody writes down the measurements. So writing them down is acceptable, but it would be better to have a device that can store the measurements in memory or do telehealth, transmit them to the office. But those recommendations are for how to measure blood pressure properly are in our guideline. I would hope over time, rather than having each office have to try to set up a mechanism for helping their patients to learn how to measure blood pressure properly, that perhaps American Heart Association or American College of Cardiology or some other group could do what we do with CPR, have simple training opportunities where we could send our patients to learn how to measure blood pressure properly.
Okay, Doctor, we have another question, and that is, where can we get the guidelines? Sorry, I must have missed this, I said.
Sure. I'm sorry, I should have mentioned it. They are, of course, published in different journals. In the journal Hypertension, they're also published in the journal of the American College of Cardiology and other journals. But you don't have to go to a journal. Just go to either the American College of Cardiology website or the American Heart Association website, and you can download the guidelines from there. Those two websites are also very useful. They have a lot of helpful information. You can get very nice downloading of the risk estimator. I think the American College of Cardiology does it particularly well. And they will allow you, for those in the age range 40 and above, to do exactly what I was talking about, to get an estimate of cardiovascular events. A challenge that we all face is in younger individuals in particular. They don't really get, they're not likely to get a major cardiovascular event in the next 5 to 10 years, but we worry about what's going to happen to them over 20, 30, 40 years. And we talk about that in our guidelines, and the American College of Cardiology website will also allow you to calculate lifetime risk for younger individuals. So those two websites are a very nice resource, not just for our guideline, but for many aspects of cardiovascular health.
Thank you, Doctor. We have another question from Ellen, and she said, very good presentation. Thank you for your research and your presentation. Might you be able to offer input on recent media regarding sodium in diet? Some news that lowering sodium is not so important. And regarding alcohol consumption, recent reporting that none is best.
Thank you, Ellen, very much for the compliment. So sodium is an area that I've been very involved in over many years, and again, it's frustrating to me that any independent, what I call independent group that's ever looked at this issue, whether it be National Institutes of Health, American College of Cardiology, American Heart Association, American Society of Hypertension, the International Society of Hypertension, the World Health Organization have always come to the conclusion that we get far too much sodium and a lower sodium is healthy for us. There are a group of investigators who believe otherwise. There are certainly very strong commercial interests who feel otherwise because the food industry uses quite a bit of sodium, and they use it for a variety of reasons, but you can take not so good food and put a lot of sodium in it and you're tasting the sodium, and it will also get you to drink more drinks and so on. There may be a variety of reasons. The recent information that has suggested we don't need to worry so much about sodium is, in my opinion, based on very flawed research. It is on poor quality research. Sadly, it is controversial, topical. It's repeatedly published in what I call high-level journals. Lancet particularly seems to like to publish this. So, unfortunately, it is frustrating to me. It is confusing, but I would strongly suggest to you that lower sodium is better. One of the things we talked about a lot in our guideline is lifestyle and the importance of lifestyle. We also talked about the challenge of how to help clinicians and their patients to implement what we know about lifestyle changes. And that's not so easy at the moment. And we need to continue to work on simple approaches, taking advantage of newer technology that will help our patients to reduce their intake of sodium, enhance from diet, not from supplements, from diet, their intake of potassium, healthier diets, trying to achieve a desirable body weight, moderation in alcohol intake. Of course, it has nothing to do with blood pressure, but stopping smoking for somebody who's smoking, because that's important to cardiovascular risk. Now, alcohol clearly is a very strong pressor. In other words, you don't need a lot of alcohol to see blood pressure go up, and we found that for years and years and years. Alcohol is an unusual intervention because it does two things to cardiovascular risk factors. Clearly, it's detrimental to blood pressure. On the other hand, at modest levels of alcohol intake, there seems to be a beneficial effect, probably mediated through high-density lipoproteins. It increases the level of high-density lipoproteins. And at least in observational studies, those with modest intakes of alcohol, 1 to 2 drinks a day in men, maybe up to 1 drink a day in women, have the lowest profile for cardiovascular complications, particularly coronary heart disease. So, on its clinical trials, our conventional wisdom is if you're not drinking, don't start. If you're already drinking, at least try to moderate the consumption of alcohol to no more than 1 to 2 standard drinks a day for men, 1 standard drink per day for women.
Excuse me, Doctor, we're running out of time, so I'm just going to say if anybody has any other questions, please put them in the chat box. In the meantime, thank you, everyone, for a great discussion, and I have a few last-minute announcements before we end today's class. A reminder that we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. And when you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with a link to the evaluation as well as a link to the event page on our website. The slides are available at the event webpage, and within the next few business days, the recording and the transcript of this webinar will also be added. I've put a link in that chat for you again. Thank you for attending, and have a great day. Also, I'm going to change this back to Gloria's contact information. If you need to direct somebody with more questions on this, you can also contact Gloria Thornton in our New Hampshire office. Doctor, thank you very much for your presentation.
Thank you, Alberta. It's been a great pleasure to be with you and the participants, and thank you for great questions. And thank you for everything that you all do to improve the health of the population. My hat's off to you. You do a fantastic job.
Goodbye, everyone. Have a great day.